one of eToy's guys, and he's here for, I don't know, a year and a half or whatnot to try to get involved in some research things or whatnot. So he's okay on English. Maybe, he'll improve, I'm sure, but
age is perfect. I mean, he does. It almost sounds like he was raised in the U.S.
What a nice guy. I mean, he's just pleasant to talk to, and I'm sure you've interfaced with him far more than me, but the few times I've had, he's just a really nice guy.
Right.
Is the advance on the computer?
There's a whole
I've been delayed by the boss.
There we go. There we go.
I'm just going to put it in my pocket if that's okay.
That's perfect. Yeah, pocket's fine. And this one I'm going to go up a little bit because sometimes the room mic is not so hot. Okay.
Charlie is done.
You should start there.
So I think we'll go ahead and get started. We have a few people kind of cruising in. So this morning we have Steve Burkhart as our visiting professor. I've known Steve a long time, as you can tell from the photos. There's maybe been a little bit of gray, I don't know, not no further balding, but maybe a little rain or something as years have gone by. We have a lot of visiting professors. Don't have too many giants. Steve has, in our world, really impacted what we do and how we talk. And a lot of you who haven't done that much sports, as you read, as you do things, you're going to see terminology come up, you're going to see names come up, and you'll be able to reflect back that this is kind of where it started. The department used to run a Metcalf meeting, which was a large arthroscopy meeting that, was the longest running, biggest facility in the world.
Rank order.
And
I'm on the board.
in 2002,
Cases that we see on the board,
when we had 9/11, when we had the Olympics here, we were having a meeting and lost a lot of money. People didn't want to travel. So when we picked the team back up,
It's way up there. It's incredible.
and
Yeah.
important to have people.
Yeah. No, exactly.
And Steve was one of those. So if you look at terminology and you start start looking in the paper, this is maybe, in our world, the single most quoted paper out there. It could rate top 5 in all of orthopedics. And this is Steve and Joe DeBeer, and this is where you get terms like inverted pair, engaging hill sacks. These are terms that you residents may begin to hear and see and say, gosh, where did that come from? And this is where it started. And then it kind of expanded on, and there's the on-track and the off-track. And again, figuring that out, how do you measure it, what do you do, that comes from Dr. Burkhart. The rotator crescent, rotator cable, anatomic terms that maybe some of the residents doing an arthroscopy see or talk about. And this again comes from Dr. Burkhart. When you start doing rotator cuff repairs, a term that comes out many times, margin convergence. And this was, how do you take this huge tear and maybe somewhat simply make it a smaller tear? And again, that comes from Dr. Burkhart. We talked a little bit last night about the L tears. You can see, again, he's pointing that out with a little flap in the tent and how that might work. People talk about dead man angle for anchors. Where does that come from? Well, it comes from Dr. Burkhart. The comma sign, sometimes if you're doing a shoulder scope and maybe one of the attendings will say, oh, that's a great looking comma sign. What does that mean? What's it from? It's from Dr. Burkhart. Another thing, longitudinal internal rotation deficit. Some of you may, on physical exam, hear about GERD or what's GERD or something. Again, you go back to Dr. Burkhart. And then obviously a lot of people know on rotator cuff, the sort of linked double row repair, which is arguably one of the more common ways that things get done now, and that comes from Steve. Steve practices in San Antonio. He was born in Texas. He is a Texan. I'm sure somewhere in the talk you'll get that flavor. Just because his horse is bigger than the one I'm on, that doesn't mean anything here. But he is a Texan through and through. He's a prolific book writer, and these are a couple of the books just on shoulder arthroscopy that many of us have and refer to, and it's really been an impact. So we'll get Stephen.
Thank you, Bob, for that great introduction. Bob and I have been friends for many, many years, and a lot of you probably don't know it, but he was, although he did all sports, knee, shoulder, and everything, was really on the early wave of shoulder arthroscopy as well. So, I'm going to talk about something that has some technical aspects to it, but a lot of it's going to be philosophical too, just kind of reflecting back on a career and kind of the struggles and the triumphs and everything that happens along the way, the friendships. This is my disclosure. I'm a consultant for Arthrex, receive royalties from Arthrex, and also some pocket money from books. If you want to make money, don't write a book. Brian Colma showed me one of his royalty checks. It was 25 cents one time. So that's about right. So this term, the burden of craft, is a term that I got from this book by Edward Tenner several years ago. I read it, and he talked about a number of professions and the burden of the craft of your profession. And he specifically talked about surgeons there. He said that the surgeon's obligation is to use his craft for the patient's greatest benefit. And we do have other burdens to our craft that I'm going to get into, and I'm going to come back to this because I want to end on this because I think it's the greatest burden that we have, and I want to give you my view of that. So a couple of years after I read this book by Tenner, I read this book, Shop Class as Soul Craft, by Matthew Crawford. Now, Matthew Crawford was an English major. I think he has an advanced degree in English. He's a very articulate guy, but he makes his living as a motorcycle mechanic. So he understands the burden of craft because he is a craftsman. So when you look at you kind of combine the message of these two books, I think that one of our burdens as surgeons is to uphold the value of manual competence, because that's what we spend our life doing. We're trying to help patients through manual competence that we receive through our training. You know, we talk about the age of technology. I think it's kind of ironic that we talk about tech as being social media, because, I mean, when you talk about tech, we're talking about surgical instrumentation advances, and there's a lot of things in physics and math and electronics going on that are way beyond social media, but nonetheless, social media gets it out there. And these are a couple of the terms I call doublespeak in this age of technology. People talk about the knowledge-based economy. They talk about value-based healthcare delivery. And I think there's a lot of mythology in this doublespeak. And so, you know, mythology also has a couple of meanings. If you look it up in the dictionary, the meaning we probably most associate with it is that it's a widely held but false belief, and it kind of stems from a false premise. And that's the way I'm going to portray it here. But for those of you who are going to be at my second talk today, we'll talk about the mythology that is more idealistic when you talk about things like the Churchillian myth. It's kind of what you aspire to be. So, but this is the one that is based on a falsehood. So, the knowledge-based economy, the OECD, Organization for Economic Cooperation and Development, defined it this way in 2005. They said the knowledge-based economy is an expression coined to describe trends in advanced economies toward greater dependence on knowledge, information, and high skill levels, and the increasing need for ready access to all of these by the business and public sectors. Pretty complicated, but this is where it all started as best I can tell. This article out of Stanford in 2004, Powell and Snellman said the key component of a knowledge economy is a greater reliance on intellectual capabilities than on physical inputs or natural resources. So that would lead you to believe that over time this type of a job is going to become obsolete and is going to get replaced by this kind of a job. And you say, well, that's good. It's good for society, it's good for people, it's good for our standard of living. But what about this manual labor job? Is that one that's going to get replaced somehow by something like this? And our livelihoods in danger. People, fortunately, everyone worries the sky is falling. Probably not. So what about this catchphrase, value-based healthcare delivery? Michael Porter from Harvard Business School coined this term, and this was the article that first appeared in the New England Journal of Medicine in 2010, and he found this value equation as outcomes over cost. Of course, the insurance companies love to quote this, and a lot of orthopedic surgeons love to quote it too. I think with all good intentions, but without really understanding the message, because his message was that medical care is a commodity, surgeons are commodities, surgeons are equal and interchangeable, so therefore we can operate medical care like an assembly line and basically reduce physicians to equivalent hourly paid workers, kind of like those guys shoveling the ditch that I showed earlier. So let's examine this mythology. Let's go back to burden of craft. Well, you know, I talked about the burden of craft is that surgeons are obligated to use their craft to the best of their ability to help patients. No question, surgery is a craft. I think it's probably the most exalted of all the crafts, in my opinion. If you go back to this book by Crawford, he said the knowledge-based economy embraces what he calls virtualism, which is a vision of the future, where somehow we take leave of material reality and just lie about a pure information economy. But the actual fact of the matter is that manual competence is going to retain its greatest value because of the fact that the trades, including surgery and surgeons, resist this tendency toward control of our remote sources. So actually, I think, you know, if you can actually do something and make something and fix something, it's going to be hard to replace that. So let's look again at this value equation here. You know, insurance companies try to distort this to be all about cost, and there's been this rush towards centers of cheapness, and they call them centers of excellence. But basically, actually, there's only a denominator of this equation. It's all about cost. But actually, there's a numerator there too. And if you get better outcomes, I would tell you that I think you're going to increase the value to a much greater extent than you would if you just decrease the cost. because as you decrease costs, or many times you do that at the expense of quality. So if you're better at your craft, you should be able to create higher value. Now, Ferguson is a British historian, and in his book, The Square in the Tower, he said that computers will be able to simulate the human brain by 2030. But I don't think they're going to be able to do surgery. Because when you look at surgery, it requires a combination of intelligence, knowledge, manual skills, and judgment that computers, I think, will never possess. But Ferguson goes on to say that disruption can be an opportunity, but it's an opportunity for whom? So it kind of pits us, the surgeons, against the bean counters as to proving what is most valuable. Is it the outcomes or is it the reduced costs? So, as I said, you know, on the outside, the bean counters want us to think they want to make us believe it's all about cost. But I think we need to think about, as surgeons, redefining the value equation. After all, we want better outcomes for our patients, and that's going to increase the value even more so than reducing costs. So I think we need to think about how we can quantify and distinguish differences in outcome. How can we do this? Well, there is a great analogy in the world of sports, and this is a great book. It's, I think, very entertaining. I really learned a lot from it, but I enjoyed it a lot. By Matthew Futterman, Players. He talks about how sports became a big business. In 1958, Arnold Palmer was the acknowledged best golfer in the world. He won the Masters, and that got him $1,500. He won several other tournaments. First place got him $500 at each one. So he needed additional employment to support his family that year as the best golfer in the world. Then he met Martin McCormick, who ended up being the first professional sports agent, and his first client was Arnold Palmer. And McCormick had this hypothesis that, or this theory that, or this belief, that professional sports wouldn't exist without professional athletes, and that someone was making a lot of money off professional sports, but it wasn't the athletes. So he needed to compensate them fairly, he needed to recognize their excellence and their skill in the field. So you say, well, how does that apply to surgeons? Well, you can just substitute surgeon for athlete in each of those bullet points. So the value of athletes for surgeons have been minimized and discounted for social balance. Sporting events or surgery cannot take place without athletes or surgeons. People will demand to see athletes or surgeons with proven abilities. So if we continue to up our game and to care about our burden of craft, I think that we're going to continue to increase that value. So let's kind of look at the burden of craft, because it is a moving target over history. And since I'm a shoulder surgeon, I've evolved into a shoulder surgeon. You can start out that way. But I just would like to look at how this burden of craft has evolved over time in treatment of rotator cuff tears. In 2016, I received this in the mail. I Orthopaedic today, I still get the paper version. And I looked at it, and I saw this at the front page headline. Open surgery still plays a substantial role in modern rotator cuff repair. It didn't say rotator cuff treatment, rotator cuff repair. And I thought, really? So I got home that evening and asked my wife to take a picture of me with that, because I thought, that's something that I just want people to recognize the incongruity of that. Because I feel like, I think as most people do now, that the state of the art in 2019 is arthroscopic rotator cuff repair. Not to say that there's never one that you're going to open, but mostly 99% of them are going to be arthroscopic. So, to get to today's state of the art, though, things have to evolve. So let's look at how things evolved in terms of burden of craft over the years and rotator cuff repair. So this is our icon of rotator cuff repair. Yay Codman as a curly-headed toddler, and then a serious young boy rather, and then a dashing young man, and then once again a serious, sober-minded senior surgeon. Codman was a meticulous record-keeper, note-taker, and this is a chart out of his book, The Shoulder. He self-published that book, by the way, because he couldn't find a publisher for it. But in this chart, look how many, the most number of rotator cuff repairs he ever did in a year was in 1912, he did 8. Then he went down to 1, and then for a period of 12 years, he did only 2 rotator cuff repairs. But that was enough, plus his observations and his sort of implications of the future of this, to make people believe that it could be worthwhile to develop a following for rotator cuff repair. And following is what really made it take off. So if you look at the 40s and 50s, this was a book by Mosley, Shoulder Lesions, and diagnosis was difficult then. You know, you didn't have MRI scans and that type of thing to help you. You had physical exams. So he came up with some ways to diagnose rotator cuff tears, particularly males with pencil-thin mustaches. He had special tests for them. He had some techniques for diagnostic injections that may be a little crude. You see, you had to have your assistant give the patient a black eye and then had to hold his arms down to give the injection. We've evolved a little bit from that, maybe. Also during that time, we had James Bateman had his shoulder book, The Shoulder and Environs, and he has what looks like a maxi open repair. He had a shoulder strap incision with an acromial osteotomy and a fascial graft on every case. And if you survived that, then you got to stay in the hospital for 3 weeks in traction like this. And then if you survive that, you got 3 more weeks in an airplane splint. By the 60s and 70s, people were more interested in cosmesis, probably because that was when you started being more fashion conscious. You had the disco haircut, you wanted a really nice incision. But you see these were still pretty generous incisions, even if you did a subcuticular cosmetic closure. This is the book by Mel Post, also called The Shoulder. Could have been copying Codman a little bit there. The Chicago treatment. Dr. Post was in Chicago. This guy in the upper left looks like he's about to be shot down by the Capone gang in Chicago. No wonder, because look at what he's about to experience with that huge incision and that huge operation. And then the lower one, I think, is rehab. It could be the St. Valentine's Day Massacre in Chicago with the guys up against the wall, but I think it's the part of their rehab. Then, if you survive that, you got to get 2 casts in the post-op period. You got a shoulder spica with the arm at 45 degrees, and then 4 weeks later, you got another shoulder spica after decreasing your abduction angle of your arm. By the 1980s, Dr. Neer published his book. He had these beautiful illustrations, kind of a kinder, gentler way to treat the rotator cuff. He had these cosmetic incisions and Langer's lines, as you can see here, but somehow, when he showed the photographs of that same operation, the incision was about 4 or 5 times as big as the one in the illustration. So I don't know what happened. Something got lost in the translation to his illustrator, I think. This video is from an Academy video publication from about 3 years ago. Look at the deltoid. First of all, we were talking about the deltoid last night at dinner, and they left a cuff of deltoid on the acromion. They've taken off at least 2/3, maybe 3/4 of the deltoid to fix a rotator cuff tear that probably could be easily fixed, or not probably, could be easily fixed arthroscopically. So by the 1980s and onward, I started practice in San Antonio in 1981, and Charlie Rockwood, without a doubt, was the most powerful shoulder surgeon in the world at that time. He was, I think, a year away from being president-elect of the Academy, and he was very vocal about talking, as arthroscopy came about, the arthroscope is the instrument of the devil. He said that even in reference to knee arthroscopy. Once it got into the shoulder, he was extremely vocal and very confrontational about it. So I chose to practice shoulder arthroscopy at probably the single most hostile point in the universe at that point. So in the 1980s, you know, you have to remember knee arthroscopy was brought to North America in 1969. So knee arthroscopy was not even extremely well done, just kind of so-so mediocre by the early 80s. So we were trying to, in the shoulder, adapt some knee instruments to use in the shoulder, but there were different problems. You could only, this was one of, I don't know if this is the exact case, but this was an early type of case that I did where I had a type 3 slap lesion with a bucket handle, labral tear, and you could use the knee instruments to excise the flap, but that's about all you could do. Until Harv Elman came up with the idea he could create a virtual space in the subacromial space. You know, we were putting scopes into the subacromial space, but you usually be in that fat pad in the back part, and you couldn't see anything. Harv had this idea, you could create a virtual space and make your own space to work and see the rotator cuff. And so I was at Jim Esch's meeting in San Diego in 1984, and Harv had this, it was before we had any shoulder holders, frames to hold these shoulders for practicing on cadavers, and he just had this thing laying on the table. He showed me how he did it, and I thought, okay, now I understand. This is how we're going to be able to repair the rotator cuff, because we'll be able to see it now. So by the late 80s, by 87, I couldn't get any company interested in making any instruments. I had a mechanical engineering bachelor's degree, and I had a lot of ideas about how we could approach this whole different set of problems in the shoulder, but I couldn't get any companies interested in it. So I found a local aircraft machinist who would make some homemade tools for me, and so I was doing side-to-side repairs with those tools by about 87. Where there weren't any suture anchors, you have to remember, till 1991. So, if you were going to do an arthroscopic repair of the rotator cuff, you'd have to do them through transosseous bone tunnels, and I did work on a system for that and did about 20 of those through transosseous bone tunnels in the early 90s by about 92. But I thought, I didn't think that was anything we should put out onto the public, because of the fact that to get into good bone, you really had to go below the axillary nerve, and I thought it was too dangerous to be teaching. I didn't want to be teaching people to go below the axillary nerve, because I knew somebody was going to bag it. One of the great things about the 80s and 90s was professional friendships, one of which is Dr. Burke, so that's when we got to know each other. This was a picture of early on when we were doing, I forget which meeting, but Dr. Esch and Wolf and Snyder, they were all excellent shoulder arthroscopists, and I had great three-dimensional surgical skills. And I think because of the fact there was this core group of people that could basically do an arthroscopic surgery with a knife and a fork, they didn't even have to have advanced instruments. That kept it alive enough to where it could continue on until we could get the more advanced instruments. This is a book I'd recommend you take a look at some point if you have some time. It's by Thomas Kuhn, The Structure of Scientific Revolutions. This was written in the mid-60s, but it really has some timeless lessons in it. This is the man who coined the term paradigm shift. It's right there in black and white. And he talked about people that participated in paradigm shifts or achieved paradigm shifts, or they were either very young and naive who just didn't know any better, or they were outsiders to the system where the system couldn't hurt them. And somebody like Albert Einstein, who was a patent inspector in the Swiss Patent Office, he wasn't a university professor when he introduced his theory of special relativity, so the university guys couldn't hurt him. So these were some of the early radical books. Dave Dietrichek, who was Lanny Johnson's partner, but Dave and Lanny Johnson had this great book on arthroscopic shoulder anatomy. It's still excellent if you can find a copy of it somewhere. Jim Esch had his shoulder book. Steve Snyder had his shoulder book. So the message was getting out there, and we found ourselves, we didn't realize it at the time, but we were at the beginning of a paradigm shift in shoulder surgery and how it was going to be done. And so we went through, as time went on, all these stages of conflict that Mahatma Gandhi talked about. First they ignore you, then they laugh at you, then they fight you, then you win. And the winning is the fun part. But the journey's fun too. So by the 90s, we were wanting some more sophisticated instruments and implants, which meant you were building a ship in a bottle, and we needed to find some companies, many of which were just, brand new, in their infancy, looking for something to do, and they were willing to help. But there are other burdens if you're at that stage in a paradigm shift. You can't just shift over to something and say, I hope this works. There's this burden of having to prove that the new technology is biomechanically as strong as the old technology. You don't want to produce an inferior product. So I felt that burden myself, having an engineering background. I didn't see a lot of engineers in orthopedics, particularly shoulder arthroscopy at that time. And so I said, well, we got to prove that this is better. So we did these series of studies, cyclic loading of bone tunnel repair, cyclic loading of anchor-based repairs. After we got anchors, I finally was satisfied the anchors were actually stronger than the bone tunnels. And so then I felt, okay, we're fine to go ahead with anchors now. We tied thousands of knots in the lab. We wanted to prove if there were arthroscopic knots were as good as open tying of knots, and actually it was superior. We could get better loop security with an arthroscopic knot than we could with an open repair. So there's this burden of understanding the arthroscopic anatomy. Nobody had looked at a shoulder from inside out. It was always outside in before. So, what are we looking at? What the hell is that? Nobody'd seen it before. So you had to figure out what it was. Why is it that way? What might its function be? Might that be a cable crescent type of a complex that might somehow act like a suspension bridge when you tear within the crescent? And might those two areas that are similar to the piers of the suspension bridge have a similar function to those piers, and they're the most important points and maybe merit a little bit extra attention when we're repairing things? And I think that's evolved now to where we do that. We try to reinforce the cable attachments. We know where the cable is. We want to reinforce those attachments. There's a burden of craft in developing instruments and implants. In the early days, before the CAD programs, computer-assisted design, you could only make straight instruments out of bar stock steel, surgical grade steel. So everything had to be straight. So we could only have things like these spring-loaded hooks that were suture retrievers. Here's just an early one. It's kind of like a hat pin with a little hook on the end of it with a spring. And then we got, once the CAD programs came in, it was gradual too, but you could make some angled instruments, so you could change those straight instruments to angled. But even so, you still had to, here's one of the things I didn't like about those instruments. Everything had to be retrograde to pass your sutures, so you're going obliquely through the rotator cuff all the time. And some people still prefer this. I didn't like it because what happens, you end up, I think, with a tension mismatch between the top of the cuff and the bottom of the cuff, because you're hitting it at different angles relative to the muscle tendon junction. So if you could just do antegrade, then you could pass perpendicular to the cuff and you would have no tension mismatch between the top and the bottom. So that was my goal next. And so our first antegrade instrument was this one, was called the Viper. And so it had, it would actually pull the suture through. It had a hook on the upper jaw and it had a little tray on the bottom that would push the suture into the hook on the upper jaw, and then you would pull it out through the cuff. But it was, because you're pulling through and it was a point on that hook, it was hard to get it to come through cleanly, and you had to do this little alligator roll kind of thing to get it to come through. So it just made sense that the next step would be an antegrade passer where you push the suture through. So, but you would want to push it through. You had to have, a curved needle that had some memory to it, which nitinol is the metal that is most efficient in terms of memory and returning to its original shape. It starts out curved and becomes straight again. So this was an early prototype on an antegrade passer with a nitinol needle. And then this evolved into this type of a passer. And then the idea was that was hard to use because you had to have two hands, one to pass the suture through, the other one to grab it. So then we got this instrument here with the trap door in the upper jaw, so that you could use one hand to pass it and capture it, because the trap jaw came down and captured the suture on the other side. This was my first knot tie. I couldn't figure, so when I was doing transosseous bone tunnel repairs arthroscopically, I was tying, because I was going down low, I would tie my knots over cortical bone. And when you're tying over a rigid surface like that, the knot always slips and you get a loose loop. And I couldn't figure out how to make the loops tight. So I thought, well, it's got to be like a kid holding his finger on a shoelace to hold the first throw while the second throw comes down. So I thought about it, and so I bought this copper tubing at the hardware store, and I cut off the nozzle with a caulking gun, and thought if you can just slide the larger diameter down the smaller one, you can get a set of half hitches going down. And so basically what that allowed us to do was to have this type of situation where you're holding a very tight loop and it doesn't slip back while you're pushing sequential half hitches down. And as I said, we'd had thousands of knots to find the best sequence of flipping your posts and reversing directions. And then we got by accident, we got these clear cannulas. We were trying to get some opaque cannulas, but all they had was the clear. And so once we got the clear, and so you could actually work, the cannula itself was a virtual space. So you could tie a knot within the cannula. So that ended up being a big thing at the time. I appreciate Bob telling y'all that I came up, that I validated this linked double row cuff repair. Actually, this study, the Curl and Job guys, Max Park, when he was a fellow with Taboni and Elatrash at Ty Lee's lab, they did a biomechanical study that showed the superiority of the linked double row. And I'll tell you why in a little bit. That's a self-reinforcing construct, right? It's like a Chinese finger trap that becomes stronger the harder you pull on it. Think about a Chinese finger trap. You pull on it, and the harder you try to make it fail, the stronger it becomes. Well, that's what that linking does between those two rows. And we've shown that in the biomechanics lab, too. So then how else can you make it better? Well, can it be knotless, larger compressive interface? That means, maybe some broader tape, like perhaps a fiber tape, improved anchor fixation. I sort of accidentally came across, I had been interested in this issue of knotless fixation, but I found kind of the beginning of my quest for this came on this trip to Hong Kong in 1998. So this was the first meeting in Hong Kong where it was the year after Great Britain had ceded Hong Kong back to mainland China. So it was kind of in a state of flux. And it was the first meeting in China where they had discussed shoulder arthroscopy. This was my host, Dr. James Lamb, the first day I was there. And then the second day he took me to a restaurant on Queens Road. And this building across the street from where we were eating was being renovated. And this was all bamboo scaffolding. And he said, after we finish lunch, I want to go over and have you look. They said all the buildings in Hong Kong, including this 100-story high Bank of China, were built totally with bamboo scaffolding. So afterwards, this was a picture I took that day, and these are lashings that are twisted and turned back on themselves. There are no knots at all. And they are confident enough in these that they build 100-story buildings with humans standing on these. So that's pretty strong. So I thought, well, we can fix rotator cuff with something like that. And so I wanted to have kind of a lashing concept. So I came home and we looked at something we were calling a twist lock concept, where you would just kind of you'd make a hole in the bone, and then you'd twist your anchor around, and it would create this kind of lashing effect down. And also you get cable friction between those two, which we'll talk about, between the two sutures. And then you'd push it down. It seemed like it ought to work every time, but you got to remember that back in those days, it was before high-strength sutures. This green suture is Ethibond suture, and it didn't take much to break Ethibond. So the flaw in this thinking that this was going to work is there's a really high stress riser right at the corner of your bone socket, right at where it turns the corner to go into the bone. And just by pushing it in there, oftentimes you would break that suture. So I thought, well, this isn't going to work. We have to have a kinder, gentler way to push the suture in there and then bring the anchor down alongside of it. This was my first knotless cuff repair in February 2000. And so I used an ACL screw because there were no anchors, or no rotator cuff anchors rather. And I just wedged the suture alongside an ACL screw, but I got lucky that the suture didn't break. And I had some others that broke, and so because of that stress riser I was talking about. So then this was my idea 2 months later, was to have an inserter that had an extended tips to it. So you'd have an eyelet on the extended tip to bring the suture to the base of your bone socket, and it would be stationary, and it would be a smaller diameter extended tip, and then you would just bring the anchor down alongside of it. It'd be relatively atraumatic. So then this went from being an eyelet made of suture material to a hard eyelet, and then it expanded from being a push-in type anchor to being screw-in type. By then, soon after we had this concept, we had the high-strength suture, so the combination of that was very good. The screw-in type anchor, I guess I can't use trade names, but you'll recognize what it is, but it's that evolved over time too. And if you have something on the ranch, Harold Dunn can appreciate this. I always like to look at examples on the ranch. How would you do things on the ranch? You can have an adjustable loop on the ranch. I mean, the chain around a gate is a great example. You can make it tighter or looser depending which link you choose. So why don't we just make suture into a chain? So we did that. We called it fiber chain. But the first of these screw-in anchors we used had a swivel tip, but it was a fork tip, so it could capture the appropriate link, and then you could put that down into the bone. And that is actually a very secure way to repair these cups. The problem is it's a little bit difficult to do. With practice you can do it, but it can be discouraging when you're first trying to learn it because it's a very fine motor movement that you have to use to capture that link. But then we transitioned from the forked eyelet to a closed eyelet because I didn't realize at the time, but you did have cable friction working for you around the eyelet, which I'll get into in a minute too. So how can you multiply the friction? How can you take advantage of friction? Well, in engineering there's this term cable friction. And there again, the ranchers may not know what it is, but they know how to use it. If you're trying to control a horse and you have a lead rope and it's you against a horse, you're going to lose every time because you can't produce as much force as that horse. But there is this thing called cable friction. If you can wrap that lead rope around a post, this picture was taken about 1900, and you see there's what they call a snubbing post where it's implanted in the ground, and the cowboy has wrapped that rope around that horse one revolution around the post. And if you do that, the cable friction reduces the amount of force you have to provide to control that horse by a factor of 5. So 1/5 the amount of horse. So all of a sudden you're equal to that horse or you're superior to that horse. So the cable friction works as you can imagine, particularly the wider the suture, you get a tape-like suture that goes around it, then it's like wrapping that lead rope around a snubbing post, and you've got a significant amount of friction to minimize slippage. People think that these knotless lateral anchors work only about friction between the bone and the anchor, but probably the bigger part of it is the cable friction at the eyelet. So, and we went to larger compressive surfaces, the tape rather than the suture. And then, so I think this is today's gold standard, the link double row, cinch loops to reinforce the cable attachments. And if you have poor quality tissue, we do these double mattress sutures medially. If you look at irreparable cuffs, the superior capsular reconstruction, we were talking about this yesterday at our conference, using dermal allograft, and to help recenter the humeral head, provide a better mechanical environment for your force couples, optimize your force couples. Mahata in Japan came up with this concept initially, but used fasciolata. I've been using this acellular dermal allograft. It's very well tolerated. And I'll briefly go through kind of what our results have been with that, but the indications are active patients with an irreparable tear of the supra and or infrasmatus, minimal or no glenohumeral arthritis, functional deltoid trapezius, an intact or repairable subscap, and then also active patients who've had a previous failed cuff repair but may have a deficient capsule. So myself and my ex-shoulder fellows, we call the BRASS group, Burkhart, what does it stand for? Burkhart something Association of Shoulder Surgeons. I forget what the R stands for. But at any rate, we reported these results, and so but I want to emphasize these were our initial results of our initial patients. So it included our index case for all of those 5 surgeons there. And so we ended up with 75% of people getting good satisfactory results. But the big concern with that paper is that of the people that returned for MRI scans, only 45% of them had totally healed their graft. And so what's the problem with that? Well, these were our initial patients where our indications weren't yet very refined or defined. The techniques weren't refined and the rehab wasn't yet refined either. So you have to take all that into account. So I just want to kind of present my own pure series of my single surgeon supracapsular reconstructions. I've done, this was in February, I've done about 175 now, but I had done 159 patients over the last 4.5 years. I had 4 failures that required revision surgery. And then these were our results at a year. You see a significant improvement in forward flexion. ASCS scores averaged about 84, which is actually quite good for this group of people. Their SANE score went up from 37 to 84, so the patients felt like their shoulder was 84% of normal. At 2 years, we've gotten them back. In this group, it's 41 patients at 89% follow-up at 2 years, and our scores actually went up somewhat. It's not statistically significant, but we're up pretty close to 90 on our ASES scores, which is really good. Pain scores down below 1. So the results don't seem to deteriorate over time if you compare the 1 year to the 2 year follow-up. And that's one of the things we didn't know, but at least over my 2 year, we're up to 3 years now, and we're seeing the same thing on the 3 year follow-up. MRIs, that was the big knock on our paper, that 45% of them had healed. In this expanded series, I had 109 patients with 1 year follow-up. And then so 78% of those came in for an MRI, so that's pretty good. And out of those, 69% were fully healed, 24% were almost completely healed. That anterolateral corner would sometimes be loose, didn't seem to affect the function, so 93% of the grafts were either fully or almost fully healed at a year post-op. What about reversing pseudoparalysis? Bob Burks agreed totally with this article he wrote about what is pseudoparalysis. And in fact, I'm using this term profound pseudoparalysis, where active elevation of only a shoulder shrug, where all they can do is that. Anyway, we published a study in November on 10 patients with profound pseudoparalysis. 9 of the 10 reversed this using the dermal allograft. We had only 1 failure out of the 10. And then you see they were all either fully or almost fully healed. So you want to go slow in the post-op rehab. That graft has to revascularize, repopulate with cells. It becomes weaker before it becomes stronger. So I keep them in a sling 6 weeks. At the end of 6 weeks, get them out of the sling and do passive motion only. And then active motion and strengthening begin at 4 months. So we're going very slow with these people. But just to show you, people think that when you say it can reverse pseudoparalysis, that it's like the early days of arthroscopy. Well, if you're doing something that's that different and that amazing, you must be lying about it. But, you know, seeing is believing. Here's a guy, 72-year-old rancher. He was told by 2 orthopedic surgeons he needed to have a reverse total shoulder. He said, I'm not going to comply with the weight restrictions on reverse. I got to have something else. So here he is pre-op. Here he is at a year post-op. This guy lives way out in West Texas. He wears the same shirt to the office every time he comes in. You see, he got the same shirt on a year later. And here he is. But it's a big day when he goes to the doctor. He goes to the city. So that's him at a year. He can do everything he wants to on the ranch. What about if you have anterosuperior escape? If you talk to guys that do a lot of total shoulders, they'll say, well, if they've got anterosuperior escape, game's over. You got to do a reverse total shoulder. Well, how about this guy? He's only 58. You'll see he's very out of shape. He's a CPA. But he was advised to have a reverse total shoulder. 58 is pretty young, but look, through his shirt you can see the first thing that happens is humerus. It goes up and anterior. So he's got anterosuperior escape. From the side, you can see it maybe even a little better. And he's got such a deconditioned deltoid that he drops down even after he gets to 30 degrees. He can't even hold it there. So here he is at a year post-op. His wife sent me this video. So she wasn't sure how, she asked him to really raise it up high. So you might make a case that, oh, he's just throwing it up. He's not really that strong. But look what happens when he holds it out at 90 degrees. Just rock solid, stable. So I don't think a reverse total shoulder would have done any better. So the big thing is that a big mug of coffee in April, just before April 15th, and he's okay. So here's some more examples. This lady, she's 66. You see, she's in the pre-op holding area. She can't even begin to get it up more than about 15 degrees. Here she is at a year post-op. She loves to garden. She now brings me fresh vegetables every spring and summer. So patient selection is key. You got to choose people that can bring you fresh vegetables. So here's a man, 64 years old, very active guy, unable to raise his arm. He even had an external rotation lag. Once again, that's something that a lot of the total shoulder guys say, oh, you can't do anything about that except a reverse total shoulder and plus a tendon transfer. It's his non-dominant arm. That's the only reason he's been able to keep going. But look at this extension lag, or external rotation lag rather. So he drops right back. He can't even externally rotate to neutral. And here he is at 6 months post-op SCR. and he had a partial repair with it. We were able to repair some of his cuff over the top. So I would challenge anyone to say that they could get a better result than that with a reverse total shoulder, but yet we've preserved his own natural joint. How about if you have a ruptured graft in someone? This is a lady, 75 years old, very actively, fell down a full flight of stairs, caught her foot, and she had been doing great up until then. She tore her graft right at the margin of the greater tuberosity. It was a transverse tear. I was prepared to just redo her graft. She still had a great joint space, a good articular cartilage, but look at the vascular markings immediately on that graft. This was actually a reverse L tear, and it reached over to the tuberosity, and there was a stump on the tuberosity that was vascularized as well. So I thought, you know, she's already vascularized it, why don't I just repair the graft? Repair graft to graft and to bone. So I used a load-sharing ripstop technique. So you see how it reaches over there. So we place the fiber tape. We have anchors that go kind of between the goalposts of the fiber tape there, and then we can tie knots. And this is a linked self-reinforcing repair as well. So very strong. Here she is at 6 months post-op. Touchdown. So she's about 1 year post-op now. I'm anxious to see her MRI when she comes in at 1 year post-op repair. So I think SCR really is a joint preserving game changer for me in the shoulder. And I think because of its high technical degree of difficulty, it's really an advanced example of the burden of craft, but there's a whole spectrum of the burden of craft as we want to get back to. And I want to get back to that initial theme of the burden of craft and doing what's best for our patient. So if we look at technological advancement in surgery, the patients think that the more technically advanced surgery becomes, the easier it is, and the less it requires craftsmanship. But we know the opposite. Is the more technically advanced, it becomes more difficult to do. And you have to practice it, you have to learn things, skills that may make you a little bit uncomfortable. But we do need to up our game if we're going to participate in the treatment of patients with that particular type of a problem. And it's going to take this attention to detail and this tenacity at learning how to do this. Now there are what I call cuff repair deniers that brush it off, and they say, you know what, the reason those cuff tears don't heal in these older people is they have a biologic deficit, they don't have the biologic ability to heal these things. But really, is it a biologic deficit, or is it a skill deficit in the surgeon? We always have to look inward and see if maybe part of the fault is ourselves. There's this trend in the U.S., reverse-mania, I call it, that a lot of people are doing reverse total shoulders and people with perfectly normal joints, and I see these as second opinions a lot, people in their 50s even, and they have massive tears that are either going to be repairable or could do an SCR, but yet they're being told they need a reverse. Why is that? And I think the reason is for the average surgeon, the reverse total shoulder is easier and faster to perform than the arthroscopic repair, the arthroscopic SCR for these massive tears. But that really shouldn't be the issue. It's not what's best for the surgeon, it's what's best for the patient. What would you want if it were your shoulder? Would you want to preserve your joint? Or would you want to be subjected to the potential complications of a much larger procedure that's a joint reconstructive procedure? And you know what? People are going to find out who can do this and who can't. It's not going to be a secret. So, but you've got to know these advanced techniques, and I would encourage you to learn these techniques if you want to take care of these patients. The British had this proverb, it's a poor carpenter who blames his tools. And you know, the tools are there for arthroscopic repair and reconstruction. You need, if you want to do this work, you need to learn to use them and be proficient at them. I still hear this from the podium. It used to make me so angry when I hear Charlie Rockwood say this all the time, do what's best in your hands. Because Charlie hadn't changed the way he had done things in 40 years. So what was best in his hands was what was best 40 years earlier. But no, I don't think you do what's best in your hands, you do what's best for the patient. If your hands can do that, then that's great. If your hands can't do it, you have an obligation as the burden of your craft to tell the patient where they can get the care that would be best for them. So I think this burden of craft is the surgeon's burden and obligation. We need to accept the challenge and responsibility of that burden. This is another great book I would recommend that all you guys read. It's Chris Ahmad, who's one of our own. He's an orthopedic surgeon and a very good arthroscopist in New York City. He wrote this book called Skill, the 40 principles that surgeons, athletes, and other elite performers use to achieve mastery. So in 2019, the state of the art, where does open rotator cuff repair fit into it? I don't think it fits into it at all. You know, my mission basically through my career has been to try to clarify arthroscopic principles for treatment of shoulder problems, and even, you know, written these 3 textbooks to try to simplify the techniques and to educate people in these techniques that a lot of work has gone into, but to just kind of condense it into something that they can utilize in their practice. And that's been my way, I think, of upholding the burden of craft. And ironically, maybe I shouldn't say ironically, surprisingly, I've seen that paradigm shift occur from open rotator cuff repair to arthroscopic repair as the standard of care during my career. I never thought that would happen. But it's been, as you get on you have that asymptotic curve where we're on this upswing now like that, and that's where you realize you get at the lower part of that upswing, you know it's going to happen, and it has happened. And so I couldn't have imagined anything more gratifying in my career. It's been a fantastic ride. Thank you.
We can take a couple quick questions. I guess one thing I would say for you guys sitting down here, if we could play a video of a couple of those repairs to Steve 30 years ago, he'd look at it and say, what the hell are you talking about? Couldn't even have imagined it. And so a lot of times, you know, it's like, hey, I'm fellowship trained. I went out, I went with the best and whatever. 20 years later, you're not doing anything that you learned hardly. And so it is a constant process, and I don't think any talk could show the change in constant progress and education than this one. And it's something that you guys, you know, as you learn, I'm just telling you, you get to be grayer or balder, and all of a sudden you're going to look back and say, man, I mean, this is a totally different world that I'm doing now, no matter what your training was, than how you learn. Kevin?
So I just want to push back slightly. You started this talk with the premise that this is the burden of craft, and this is about sort of, you know, manual competence. And then you proceeded to show us a bunch of conceptual advances that these were not, you know, that one person was more skilled with their hands than somebody else. It was that you had a different idea, and you pushed that idea, and you tested that idea, and you moved it forward. But how much of this advance was learning how to use our hands and conceptually how to use our hands in better ways, more than finally tuning some, you know, athletic skill at, you know, dunking a basketball or something?
No, it's not pushback at all. I mean, that those are parts of the same, I guess, the same module, if you think about it, that's going to advance your field. You know, I don't see a lot of twist locks being done today. That was a concept, but it led to some other concepts that worked. And we were talking about that at dinner last night. I think, you know, Bob Tasman mentioned that as, you know, arthroscopic ladder J. You know, we all feel, I love to do arthroscopy. That's the only operation I don't do arthroscopically, because I think it's not simple enough, even for very skilled surgeons, to do without significant danger to the patient. You know, even guys like Laurent Lafosse are still getting axillary nerve palsies after doing hundreds of those. So I think, as I mentioned, you know, there are these various, if you're going to be involved in something at some point, whether you realize it or not, but whether you actually are involved in a paradigm shift, there are these cascading burdens. You know, you have the, you know, kind of the burden of, yeah, you can have the concept. You have to have the concept before you can try something new. But then you don't try it. I mean, our lab is not the patient population, so we're not trying unproven things. So you have to do the biomechanics to prove that it works as well as the open technique. You have to understand what you're looking at. If you're looking at something new, like with arthroscopy, well, is that something that's even pathologic? Do you even need to repair it? So you have to go through, I mean, we're talking about, this is a 30-plus year, experience. And everyone thought we were crazy. I mean, for the first 15 years of that, we were either crazy, or we were lying, or there was something wasn't quite right about us. But you know what? We were all outsiders. When you think about it, Steve Snyder, Jim Esch, myself, we were all in private practice, so I wasn't going to lose my university position. We were all very young, at the time, very young and naive, so it kind of all fits with Thomas Kuhn's theory. So anyway, it's a stepwise thing. And so the final thing is what Chris Ahmad is talking about. So it's out there, it's difficult to do. How can I optimize my skill to be able to do it?
Fisher.
Given up some nice history the last 30 years, how do you see the next 30 years?
I don't have a crystal ball. That's another thing we talked about last time. I think there's something out there that none of us can even imagine right now. When I was a first-year resident at Mayo Clinic, my second rotation was with Mark Coventry. Mark Coventry was an icon in orthopedic surgery at the time. He had done the first total hip replacement in the United States and kind of brought that technology over. And many a time I thought, if I were just Dr. Coventry's age, I wish I was a lot older, because I could have gotten in on this one new technology that we're going to see in the 20th century in orthopedics. Not realizing that right around the corner was arthroscopy. Who would have known? And I didn't miss that one. Maybe it helped me to recognize, to get the second cab when I missed the first one. But, I don't know. We talk about, I guess the thing that people talk about, they say, well, the mechanical part of it is really good now, so we've been through all the fixation, how to do the techniques. Now it's going to be all biologic, and there may be some magic dust we put in there at the end that'll make it all heal. But I think there's something way beyond that. There's going to be some genetic engineering that's going to allow us to actually replace portions of the biology with adult stem cells from that patient, that you're going to grow bits of rotator cuff from their own adult stem cells.
We're all going to be lizards and salamanders when we just go. All right, well, thank you very much. Thanks.
Thank you. Okay, Charlie. Yeah, thank you. Thank you very much. Yeah, thank you.